Yeah, so we are live. So good evening.
Thanks, time and place.
It's indeed a great pleasure to welcome all of you for this webinar, a joint webinar of Asia Pacific Arthroplasty Society and OrthoTV along with the Sancheti Institute. So it's a great moment to see all of you. I take pleasure in welcoming Professor Thorsten Gerke, who's going to moderate the session, Dr. Amar Ranawat from HSS New York, Vijay Bose from Chennai, India, and along with the great panel, Dr. Mahesh Kulkarni, Dr. Rajiv Joshi, and my father, Dr. KHS. And we also have the president of Asia Pacific Arthroplasty Society, president of Asia Pacific Knee Society, and ASIA, Dr. Professor Nicholas Budiparma join us. So over to Dr. Nicholas to say a few words, and then we hand it over to the coordinator for today, Sahil. Over to Nicholas.
Thank you, Parag. Good evening and afternoons in Europe. Welcome to today's webinar. It is collaborations between the APAS and the Sancheti Institute and OrthoTV. And thanks to Professor Parag Sancheti that make it happen. I think he's the pioneer in broadcasting the webinar all over Asia Pacific. And today's webinar is on bearing surface in replacements. And the question is now, which bearing surface is to choose and why? We are going to focus on discussions on ceramic or ceramic and poly. I think this discussions is about bearing surfaces very crucial. Since a few years ago, we know that the world was shocked by litigations pertaining to metal on metal bearing. And the argue was that metal on metal is the only material for long survivorship, especially for the young surgeons. And now the question is whether ceramic can replace metal on metal, and whether ceramic on ceramic has a better survival rate than ceramic on poly. We are happy today to have my good friend here, Professor Thorsten Gerke from Endo Clinic, who's going to moderate this session, since I think he does the most revisions hip in the world, I think, because especially PGI and with the bearing that he will suggest us. And we have the faculty here, my brother Amar Ranawat, though that his body is in New York, but I almost see him every month in Asia Pacific to give all this, to educate all the surgeons here. So, and also my good friend here, Vijay is also here, and they're going to have a debate on which bearing will have the better survival rate, and especially for the young surgeons. So for without further delay, let's start the debate. I hand it over to the moderator.
Sahil.
Yeah. So good evening to all our viewers from the East, and good morning to all our viewers from the West. I'll just share my screen in a minute. So today's webinar is our second webinar in the APAS HIP series. The previous one we did was on anterior versus posterior approach for total hip arthroplasty. And today's webinar is about the choice of bearing surface for total hip arthroplasty in young adults. So we have Dr. Amar Ranawat, who will be speaking for ceramic on poly, and Dr. Vijay Bose, who will be speaking for ceramic on ceramic. So Dr. Amar Ranawat completed his medical degree from the Weill Cornell Medical College, and thereafter completed his residency from the Hospital for Special Surgery in New York. Thereafter, he did his fellowship from the Lenox Hill Hospital under his father, Dr. Chitranjan Ranawat. He was awarded the Hip Society British Traveling Fellowship and the OREF grant for MRI in early detection of particle disease following total hip arthroplasty. He is a reviewer with esteemed journals like CORR, JOA, the HSS Journal, and Current Orthopaedic Practice. He's received the James Rand Award for the most outstanding paper in knee surgery and the Chief Resident's Special Award as well. His areas of interest include alternative bearings in the hip and the rotating platform technology in the knee. Dr. Amar Ranawat, we welcome you to today's webinar.
Thank you for having me.
Dr. Vijay Bose is the Joint Director and Consultant Orthopedic Surgeon at the Asian Joint Reconstruction Institute and SRM Institute of Medical Sciences, Chennai. He did his MCH in orthopedics from the University of Liverpool and thereafter completed his FRCS. He's received numerous awards like the Lieutenant Colonel Thayu Munaswamy Gold Medal Award, the Young Achievers Award, the Best Doctor Award from the Tamil Nadu Dr. MGR Medical University, and he was recognized by the Honorable Governor of Tamil Nadu for his exemplary contribution in the field of hip arthroplasty. He's been the past president of the Indian Arthroplasty Association and has also been the fellowship chair for the Indian Society of Hip and Knee Surgeons. Dr. Vijay Bose, we welcome you for today's webinar.
Thanks, Sahil.
Our moderator for today's webinar is Dr. Thorsten Gerke from Germany. He is the Medical Director and Chief Physician for Orthopedics at the Helios Endoclinic at Hamburg. His areas of interest include aseptic and septic revision surgery of the hip and knee, and he has done pioneering work in one-stage revision total joint arthroplasty. He's been the past president of the Congress of the North German Orthopedic and Trauma Surgeons Association. He's been a visiting professor in various countries like China, Colombia, the University of Chile, Argentina, and Kuwait. Dr. Thorsten Gerke, we welcome you for our webinar today.
Thank you so much. Hello, everybody.
Our guest faculty includes Dr. Mahesh Kulkarni, who's an arthroplasty surgeon from Pune, and Dr. Nicholas Buddhiparma, who's the president of the Asia Pacific Arthroplasty Society.
Thank you, Sahil.
Our panelists for today are Dr. Rajiv Joshi and myself, and we also welcome our patrons, Dr. K.H. Sancheti and Dr. Parag Sancheti. So I'll hand it over to Dr. Amar Anawat, who's our first speaker, who will be speaking for ceramic on...
Thurston Gerke is giving some opening remarks, isn't it?
So we have a prelude to the debate, and Dr. Thorsten Gerke will be giving his introduction to today's topic.
Thank you so much, Sahil, for this very kind introduction. And so what we are, hello, everybody. First of all, I'd like to say hello to everybody. And I'm really proud. It's a great honor for me to be part of this wonderful webinar, to be together with all of you again and in these dark times. So it's always good to meet great friends again, even if it is virtually. At least we see each other, we hear our voices, and so we are, in a certain way, we are together. And great honor for me to be against the moderator of this very interesting session, which is dealing with the debate between ceramic on polymer, ceramic on ceramic, focused on THR for young adults. So I give you two examples of patients from my patients of the last 2 weeks. 2 weeks ago, I operated this young girl, 16 years old, from St. Petersburg. And the question is, what should we do here? 16 years old. Yesterday, I operated another young girl from Moscow, 18 years old. Both of them suffered of aseptic necrosis of the femoral heads due to chemotherapy. And also here is the question, what should we do and what should we use in this kind of patients? What about young patients? There are several studies about young patients where you can see there is, at least in idiopathic arthritis, a difference in between patients of younger than 25 and older of 25. If we go to the registries, here the Norwegian registry, who overlooked about 110 patients in the mean age of 17 years, they reported in this registry a 10-year survival of 70%. And here you can see what kind of bearings they used in their patients. The largest review about patients younger than 30 years probably is this review, which was a mean follow-up of 8.5 years. They concluded that the patients are not necessarily more bad results than older patients. And the uncemented acetabular components that have been shown to have the lowest rates of implant loosening in these youngest patients. And they suggest that all uncemented THAs may outperform in patients younger than 30 years. But nobody is really telling about, or was telling about in these studies, about the bearing of these in these young patients in specific. So here are our main choices: highly cross-linked, vitamin E, ceramic on ceramic, and metal on metal. Some other choices are available on the market, but these are used still quite rarely. If you look at the data from US, you can see a clear rise of ceramic on polyethylene and a decrease of usage in metal of metal, of course, as Nico said already, and in metal on poly. But what about patients, very young patients? Here is a case study, a single case study of a 13-year-old boy who received ceramic on ceramic. Another paper from the Mayo Clinic, they reported in very young patients, mean age 16.4 years, a survival rate of 96% with very good outcome and functional results. And another study from France, the same 10-year results in very young patients, about 17 years, about 90.3%. So again, I tell you what I did 2 weeks ago with a 16-year-old girl. I implanted a cementless implant and with ceramic on poly. And yesterday, the same, 18 years old, bilateral hips, also ceramic on poly. And now I'd like my both friends, Amar and Vijay, to give their notes about their opinion of ceramic on poly, or Vijay is going to talk about ceramic on ceramic. I'd like to ask first Amar to give us your view about this topic. Please, Amar.
Thank you, Thorsten. It's great to see all of you. Oops, I got to go to the beginning. And thank you for having me. I really appreciate the opportunity. You can see my slides?
Yes.
Yep.
Great. So I'm going to talk about my clinical experience with using ceramic on poly, the Biolux Delta material against highly crossing polyethylene. The interesting thing about my talk, I won't be quoting other people's data. Everything you'll see will be my own data. I do have to disclose that I have received research support from Ceramtech in the past. So I'm going to make the argument using my data that this is a nearly perfect bearing and it should be used in almost everybody. I think you can always make an exception and you should never close your mind to individual cases, but you need to have some general rules and some guidelines. The first thing I want to mention is Dr. William Harris, who basically developed highly crossing polyethylene, made a statement a few years ago where he said wear rates are now independent of head size. Because that was one of the biggest problems with using polyethylene in the past, is that we knew once you got greater than 28 millimeters in diameter, that your volumetric wear would go very, very high. So the introduction of highly crossing polyethylene allowed us to use larger head sizes. So let's talk about the hot topics in ceramics. There's always a concern for fracture. That's number one. Squeaking, ceramic on ceramic hips. What is the actual wear? Metal ions, trunniinosis, dislocation, and infection. These are all issues that come across when you deal with ceramics. Well, let's talk about fractures. The reality is once you get past 28 millimeter heads, which I almost never use, the vast majority of my cases are 32 millimeters in women and 36 millimeters in men. And that's really a function of the size of the acetabulum. I think if you're using highly crossing polyethylene, you want to have around 5 to 6 millimeters of poly thickness. So that really is what determines your head size. But if you look at that, above 32 millimeters, the risk of fracture is negligible. And I'm not really aware of any ceramic fractures greater than 28 millimeters using the Biolox Delta ceramics. It certainly was a problem with the Forte ceramic in the past and other ceramic designs in the past, but the Delta ceramics have been performing exceptionally well. So simply put, in my mind, ceramic head fracture is a non-issue. Squeaking. This is a paper that we published almost 20 years ago now. It showed an incidence of 3.4% of squeaking. And multiple reports have shown that ceramic on ceramic hips will squeak somewhere between 1 to 3%. It doesn't seem to have a long-term clinical effect, but it certainly is socially unacceptable to have a hip that squeaks every time you get up from a chair, for instance. The fact of the matter is ceramic on poly does not squeak. So for me, squeaking is a non-issue as well. So let's start to talk about wear. If you use conventional polyethylene, if you have wear greater than 0.1 millimeters per year, you will get osteolysis and loosening via a histiocytic response. This has been well described and written about in the past. We did a study using Biolox Forte against metal on standard polyethylene. And after 15 years, there were no revisions in the ceramic on poly, and there were 3 revisions in the metal on poly. What this suggests is that if you're using conventional polyethylene, a ceramic bearing or a ceramic head absolutely makes a difference. But again, this was with conventional polyethylene. Now I'm going to show you my experience using large ceramic heads against highly crossing polyethylene with a minimum of 10-year follow-up. The bottom line, the wear was almost identical in both groups. In fact, it was a magnitude less at 0.022 millimeters per year. It's so low, in fact, that it's very difficult to measure the wear, and you can get very confusing data with negative values. But the reality is, at 10 years, ceramic heads did not offer an advantage with regards to wear using highly crossing polyethylene. So I'm not selling it as a wear reducer in the first decade. One of the main reasons I use it is to avoid this problem, which is corrosion due to trunnion problems and elevated metal ion levels that can come from using a cobalt chrome head. This is a devastating problem that is nearly impossible to restore this patient back to normal function. So it's catastrophic, and it can occur very early, in a few weeks to months after surgery. So I don't like the idea of risking this condition in even an older person because it could be a devastating issue. And one of the other issues, I don't want to go into it, I don't have the time, but there's no question that ceramic heads offer scratch resistance, which is very important. If you get a dislocation, your ceramic head will not scratch. And there have been numerous reports now that have shown if you use ceramics in your total hips, there are decreased dislocation rates and decreased infection rates. But let's go back to the metal ion issue. I can show you a prospective study that we did measuring metal ions in patients that had both ceramic and large metal heads. 56% of patients with metal heads had elevated cobalt levels, as well as elevated chromium levels. Nobody in the ceramic group had elevated cobalt levels. So metal heads result in higher metal ion levels, and no patient with a ceramic head appears to have elevated metal ion levels. So you can mitigate this problem if you use ceramic heads. So as a discussion, the wear rates are exceptionally low, and I've documented wear rates as low as 0.018 millimeters per year. We have no concerns for metallosis, no concerns for adverse local tissue reaction. We have not seen ceramic fractures, no noise, and no osteolysis, up to even 15 years. So as a result of these studies, I use 32 millimeter and 36 millimeter ceramic heads in all of my patients. The only issue is cost in my mind, and because of the volume that even Thurston described, that issue is coming down. Just to give you some more data, you can see the ceramic head usage increasing with metal and ceramicized metals decreasing. This is the American Joint Registry. Over the last 5-6 years, you can see again, metal head usage going down and ceramic head usage going up. So this is a common trend in all registries and in all parts of the world. So in my opinion, ceramic and highly crossing polyethylene is the new gold standard bearing for total hip arthroplasty. And I use it in everyone, regardless of age, the very, very young, as this debate is about, and the very, very old. Thank you very much.
Thank you very much, Amar, for this very, very clear statement. And now I'd like to ask Vijay to tell us your opinion about bearings.
Thanks very much, Thurston. I'll just share my slides. Yep. Can you see my slides?
Yes.
Yeah. So thanks, Amar, for the very nice talk. Enjoyed that. So my thing is to talk on the ceramic on ceramic, and this is the debate. And you can see who is Amar here. Yeah, that's very clear. Right. So this is Thurston Gerke. Now, why am I putting the moderator's photo here? I believe that if you put the moderator's photograph, you usually tend to win the debate. No, I'm just joking. Is very frequently, Thurston says, there are 3 landmark breakthroughs in hip arthroplasty since the age of Charnley. And they are trabecular metal, cross-linked polyethylene, and taraxamic acid. I think there's a great statement to make, and I think it's very true. If Thurston says something, it must be surely true. So there's no question, as Amar outlined, that the cross-linked poly has been a fantastic advancement. It's been a generational change from conventional poly. Osteolysis has been dramatically reduced. There's no role for conventional poly anymore. We, of course, all agree on that. But the question is, if cross-linked poly is so good, is there no role for any other bearing? That's the real issue that we want. I have to state now that my workhorse bearing is ceramic on poly. However, there are indications in which I use other bearings, and that's really the focus of my presentation today. So Amar said that he uses only one bearing for all comers, which would be ceramic on poly. Well, hip pathology is a spectrum, you see, and we tend to, especially in Asia, operate on very, very small patients. So we've got a large number of children on whom we do arthroplasties on. And on the other end of the spectrum, you have the superactive male patients. Andy Murray had a hip resurfacing recently, and he participated in the French Open. I'm sure you can't participate in the French Open with a ceramic on poly. So the spectrum, there are indications in which you have to employ other bearings. You can't put the ceramic on poly on all comers. So that's really the point. So this one-trick poly or pony will not work in all patients. So this is my series of hip arthroplasty in teenagers, 83 so far. And you can see a lot of them are 15, 16, youngest being 11, 12. So we are getting a lot of referrals for these. And obviously, we're not talking about decades, not as Amar said, we're not talking about 10, 15 years. We're look at decades in the future. Then you probably have to think of something else. So when we take on these very young patients, we've got to ask this question, are you violating the golden rule of elective surgery? Do the risks of operating on these very young patients outweigh the benefits? We have now 3 tools, I think, that has given us the power to deal with this difficult situation, making the benefits actually outweigh the risks. And these are, number 1, delta and delta ceramic bearing. Number 2 is this larger technology giving function. I will go into all this. And third is a bone conserving philosophy. Now, all three of these are connected to the delta and delta bearing. Now, why is COC important when you have this large head concept? Now, one of the slides, Amar did say that all his bearings are either 32 or 36. That's true for the Caucasian population, but unfortunately not true for the Asian population. I'm sure Nico would agree with that as well. So how big do you want to go? So, I also don't use 28 anymore. We go till, 36 usually, sometimes 40, beyond which it's of no value. It's been well documented that is you cross a point of diminishing returns. No point increasing your head beyond 36, 40. So we want to go. So that's the cutoff mark. Now the modern nomenclature for femoral head size would be 22, 28 would be small heads. 32 would be medium or large. It'll be a large head in a small sized acetabulum. It'll be a medium head in a large sized acetabulum. 36 is a conventional large head, and 40 with elderly patients, we tend to use an extra large head. The jumbo metal on metal THR is extinct and should not be part of any discussion now because not being manufactured like the conventional photography film, so should not participate anyway. Now, is dislocation still a problem? Oh yeah, it is. This is the recent data from NJR UK, and the second most common reason for why they would revise their hips would be dislocation, just next to aseptic loosening. And here's a paper from UK again saying that the increased femoral head size will give you more stability. Another paper from India, IJO, showing the same cause. I think nobody agrees with that, and Amar also agrees with that. Now, we all know about the jump distance, but what we really don't know about much is this intracapsular dead space. So when you use a small head, 22, 28, sometimes even a 32 head, the head can dislocate within the capsule. This is the intracapsular dislocation. So you may close your capsule with the 5 bond or whatever you want, or fiber tape or whatever. It doesn't make any sense because it's going to be intracapsular dislocation. Closing. However, if you have a bigger head, you find that you cannot have an intracapsular dislocation, and that's where the real role of head comes in when you have a thing. So here is a patient whom I have done my reduction, but still I'm able to put the same size head. Small head, you can put that, before closing the capsule. So what this got to do with ceramic or ceramic? Problem is one needs to have minimum 52 millimeter socket for be eligible for a 36 head. So I'm sure I'm not eligible. It being an Asian, I'm sure all the panelists or all Asians are not eligible, at least most of them. So 75% of Asian male patients are not ineligible for the 36 head. Virtually all female patients. So Amar's argument that he does 32 head would not hold good in Asia because we are operating on 42, 44 size. And what do you do for those patients? That's really the issue. So this is the Asian paradox. We have very small acetabular size, but we need to have a very extreme range of movement for the cultural context. And that's really is the problem that we face in Asia. So we have ceramics and ceramic bearings, which now allow us to do that. So if we see these bearings, small 42 cup, you're able to get a 32 head, 44, 32 head. So I'm able to avoid a 28 head, which would cause dislocation. And I'm able to go either a medium or a large size set. And that really is the role of delta immersion in Asia. And you can see I've done multiple cases like that, all with function. And you can see the size of the head in my palm, extremely small sockets. And with this ceramic on ceramic technology, we're able to get either a medium or a large head inside. And that's a critical difference for these patients because we're able to restore their normal lifestyle. Now, Amar said, where is not a problem? Where is may not be a problem for 10, 15 years. But what about the decades to come? Now, Fisher described the same thing that Amar talked about, that if you have less than 0.1 millimeters per year, it won't be a problem. Now, volumetrically looking at it, the magic number is 38. Volumetric analysis. Now, if you have an increased head size and a thinner poly and a higher activity level, that is the equation that you're going to see where in the crossing poly in the coming decades. You can only push a thing so much till it breaks. If you push crossing poly, it's only a matter of time, matter of a few decades before it breaks. No question about that. So wear reduction is great in the crossing poly, no question about that. About 73 to 87% wear reduction. So you may get 2 times, 3 times conventional poly, but this is still inadequate for a very young patient. So now a lot of reports coming up. When you use a thin poly, bigger head, we said is very essential today. When you use a bigger head, you have to use a thinner poly, especially in small sockets. And then you have a lot of reports coming in with breakage of cross-linked poly. And here's one with the annealed poly. Again, same issue, thin poly problem. Here's another one, same issue, cross-linked poly problem. So if we go to the next point of longevity of ceramic on ceramic bearings. Now, we are not talking about 10 years or 15 years anymore. We want to know, is it going to be 4 decades or 6 decades? That's what we're talking about. And that, I think, really the role of ceramic on ceramic comes. And here's a very interesting paper which shows that ceramic on ceramic with fewer dislocations and muscle degeneration by preserving the muscle progenitors. So there's no question that the wear is much less in ceramic on ceramic when compared to ceramic on poly. It'll take a few decades for it to manifest, and that's the reason for all this lower infection. I disagree with Amar that the lower risk of infection in poly with ceramic is not because of the crossing poly or the ceramic, but because of the low wear rates in ceramic on ceramic. So here's the paper, 10 years, absolutely no revisions, ceramic on ceramic bearings. Now, typical patient of mine, 17-year-old, like Thurston showed, I would use a large head ceramic on these patients because I'm looking at 4, 5, 6 decades of longevity. And that's what I would do, a delta motion on them. And then, of course, they can do all their functions. Another patient, this patient is only 12-year-old, idiopathic condylosis. And again, I've done a ceramic on ceramic. Now, when you have the functional scores, the HHS is not sensitive enough to bring out the functional level in these patients. So we tend to have what's known as the Asian hip score, in which we have the ability to kneel, ability to sit on the floor, and ability to sit cross-legged. And then we find that most of our patients with this big and medium heads are able to do that. Now, Amar did talk about the squeaking in the ceramic. We'll come to that in a minute. Ceramic breakage, as Amar said, is a non-issue today. And today in 2020, if at all there's going to be a ceramic breakage, it's liner breakage, it's going to be because of the mal-sitting of the liner. Otherwise, there's not going to be any breakage, 2020, with delta ceramics. And you can always see in the pre-op, in the post-op film that the surgeon has not seated the ceramic well. Now, our experience, we have done 919 ceramic on ceramic bearings so far in 2011. We have had no fractures, no dislocations, no infections. 2 patients reported noise. I'll show them. 1 patient with persistent groin pain, 1 with probably lack of cup osteointegration, no cup loosenings, and 1 cup not delta motion cup not bottoming out. Now, this is the patient that's squeaking. This is first the top is a patient from Pune. She's that is a very small patient. You can see that 42 delta motion cup, 32 head, number 6 corail, and she had a transient squeaking for 2 months. After which both of these patients were yoga practitioners. The next patient was from Canada, and then you can see that that's the posture. She still continues to have squeaking in some postures, and when I asked her to send a photograph on when does it squeak, that's the posture. You can see here. That's the posture she is when it starts squeaking. So extreme range of mobility is a possibility, but it's not been a clinical problem. So competent positioning is the key in hard on hot bearings. You want to get, I always talk about this parallelism between the acetabular and the femoral head. If it is there, then probably squeaking will be a non-issue if you employ hard on hot bearings. Now, PGI, Amar did mention about that, and if we see that is ceramic on poly, you can see that it is good, but ceramic on ceramic is the best. Now, more and more papers, Parvezi has published a lot as well, that we are going to see more in future if we use ceramics, that in the coming decades, it's just a function of the wear debris. More the wear debris, the more the chance of infection. The less the wear debris, the less the chance of infection. So you'll find that ceramic on ceramic is going to score over ceramic on poly in the coming decades to come. You can see that very clearly in this data. Now, another very interesting, more recent data is that we find that that's low for ceramic on periprosthetic fractures is low. Now, this may be very surprising, and people may laugh at this. This is how we were earlier on with regard to the infection as well. Now we seem to agree that PGA is less with ceramics. Now we see this paper. There's only 1 periprosthetic fracture for a ceramic on ceramic, but it's very high for a ceramic on polyethylene. So as Amar said, crossing poly on ceramic may be good for 10, 15 years, but you're looking at problems down the road. So in young patients, I think it's a great idea to go ceramic on ceramic. Now, what about bone conservation and ceramic on ceramic? Now, of course, we have good implants on the femur. So even when we operate on very young patients who are 12 or 13 years old, we have a game plan for the rest of their lives. So I always call it the 2 bites of the cherry. So you use a low profile taper, and then you can have 2 good shots at revisions. Should they fail decades down the line, first time you use a S-ROM type stem, second time you use a good diaphyseal stem, you get 2 bites of the cherry. But now we have got 3 bites of the cherry. That's really reassuring. Ceramic on ceramic, especially one particular model, the Reserve, seems to be doing extremely well, and reports coming in. And here again, we find that, in young patients, small socket size, etc., this is going to be, this opens a new chapter in the hip reconstruction of children. It truly does open a chapter in the reconstruction of the young patient. Yeah. Now, this is the new design we're talking about, Reserve, seems to have very good wear data and seems to be very, very promising for the years to come. So in conclusion, I want to say, so that's Amar with this one-trick pony or poly, as you want to call it. And then that's me. I think you need to have an a la carte approach. So ceramic on cross-link poly is my workhorse bearing, no question about that. However, when I have a very young patient, especially the small socket size and high activity level, I would go ceramic on ceramic. In superactive male patients or professional athletes, I would go metal on metal with the Birmingham hip. And in anyone who has got I think, a higher chance of dislocation, I would do a dual mobility hip. So I think this is a more practical way of doing things rather than sticking to one approach, have an a la carte approach. So thanks very much for the opportunity. Thanks very much.
Thank you very much, Vijay. Great talk. I mean, very convincing, very clear, very subjective. So the goal and the duty of moderator is always to make this debate a little bit more objective, and I try to do my best because, of course, everybody has his own preferences. Of course, as well. So our main choices you can see here. Let's try to make it a little bit more objective by looking at bigger data, by looking at registries, for example. And here for the Dutch arthroplasty registries with more than 200,000 patients, they reported a 9-year, of course, follow-up lower risk of COP and CLC compared with traditional metal on polyethylene, but that's clear in the meantime. And they reported also that the ceramic on polyethylene, of course, is trendy. There's an increasing trend to use it, and it is, at least in Netherlands, and most frequent used bearing. So, and you mentioned it, Vijay, the risk of PGI. Here's a systemic, in my opinion, the biggest systemic review and meta-analysis about the infection rates, PGI rates, by comparing all the different bearings. To be honest, they found in this big meta-analysis no evidence that bearing choice influences the risk of PGI, except metal on metal, what you in some cases still use. So in the consensus meeting, we came to the same conclusion, and we came up with a recommendation that there is a higher incidence of PGI with metal on metal. So that's clear. Every bearing has strengths and weaknesses, and we have further already that the weaknesses of ceramic on ceramic bearings are noises and fractures due to malpositioning. We have also heard that the main risk factors for squeaking, for example, are component malpositionings, the stem design, the cup design, some kind of impingement, loss of lubrication, and due to some papers, BMI. So, but all the big series, like your series with more than 900 patients, shows a very, very low risk of fracturing. Here, the paper from Argentina, almost 1,000 patients, just one line of fracture and one femoral head fracture. Today, it's clear that Delta ceramic, of course, has a much lower fracture rate than the old Forte ceramic. But if you compare, and that's the goal of this webinar, COP versus COC, then we came up with the conclusion that probably they are not different in total because ceramic, the New Zealand Joint Registry showed that ceramic on highly cross-linked polyethylene had the lowest all-cause revision rate and superior to all other, including COC bearings. And highly cross-linked PE seems to be one of the best, as we heard from Amar already. And this is a very nice paper. We have some nice papers and slides, because even if you have a very small thickness, thin thickness of the polyethylene, you must live more than 116 years with the prosthesis to develop some problems. So especially, and let's come back a little bit to our main topic, young patients. So here, of course, ceramic on ceramic works fantastic in very young patients. This paper from Korea shows that they had a survival rate of 6 years of 100%. Another paper from Korea, 100% after 10 years in patients lower than 30 years. But if you look at the whole literature, you cannot find really a significant difference in regarding ages, regarding outcome, regarding risks between COC and COP. All these paper reported similar results of COC and COP. And especially also in patients in young patients, and that's a very interesting paper. Mean age was 45 years, where they did bilateral, one side ceramic on ceramic, the other side ceramic on polyethylene. And as you can see, the clinical and radiographic results of using COC and COP, highly cross-linked bearings, were similar. So in total, no difference in these patients who received one on the other side and the other one on the other side. So our philosophy, at least here in Hamburg, is regarding fixation, younger than 75 years cementless, older than 75 years hybrid, of course, cementless cups. And regarding the, we always using highly cross-linked polyethylene, but in younger patients, younger than 75 years, Biolox Delta, and in older patients, is a much cheaper Biolox Forte or even metal if the patient is over 80 years. So to conclude and to try to make it a little bit more objective, at the end, it seems that the results are the same, or let's say similar, with little differences. COC is less forgiving than highly cross-linked polyethylene. Metal on metal, of course, seems to be obsolete, and we use always, as Amar does it in every patient, ceramic on highly cross-linked patient, at least in all our patients younger than 75 years. Thank you so much. And now I'd like to open the panel discussion. First, I'd like to ask all our panelists, to be honest, what kind of bearing do you use in your daily work? Or do you have the same philosophy like Amar to use ceramic on poly or COC in all your patients, or you are more differential like Vijay? I'd like to ask our main host, Parag, how are you doing it?
So I'll pass the question to Dr. Joshi, who does more hips at Sancheti.
Okay, Dr. Joshi.
Hey, if we are doing it in a younger patient, my preference is ceramic on ceramic. Anything above 55 years of age, I would go ceramic on poly. Hardly using metal on poly.
Your cutoff is 55 years.
More or less 55 and activity of the patient. We feel that around 55, the activity of majority of Indian patients slightly decreases. They are nearing their pensionable age, which is around 60, 58 in some people. And after that, they do decrease the amount of activity they have. So I would go for less than 55, mostly a ceramic on ceramic. More than 55, it would be ceramic on poly.
Mahesh?
Peter, you also mentioned that you differentiate, you're differentiating between in the ages. What is your cutoff regarding age, Vijay?
I would say less than 30, I would go ceramic on ceramic. And after that, I would go ceramic on poly.
Okay. Parag, you wanted something to say.
I wanted Mahesh to comment on his bearing surface preferences.
Okay.
Yeah, my preference is ceramic on poly for most of the cases. However, there are some patients who are well read or have been convinced by other surgeons to go for the more expensive bearing, which is ceramic on ceramic in our country. and they feel whatever is more expensive is probably the best thing to happen to them. So they have the money, so they will demand to have a ceramic on ceramic. But I would stick to ceramic on poly being my choice of bearing for nearly most of my hips.
Sayed, what's your opinion about it? Do you have a cutoff?
Young patients who are active with good bone stock, I'd prefer ceramic on ceramic. But in a complex primary situation, even in a young patient, because ceramic on ceramic is less forgiving, in those cases, I'd be biased towards ceramic on poly.
So Mahesh just mentioned the costs, and you did it as well, Amar. Do the costs play a big role in your decisions, Amar?
Yeah, I mean, in our system, no. The patients don't have to pay for their implants. So I don't think cost is a major issue. Certainly the cost of revision surgery is very high. So any minor cost that you pay upfront to mitigate revision, I think is probably worth it. You know, I think one thing that we need to be careful of is we talk about ceramic on poly, we talk about ceramic on ceramic, but we can't take that out from the implant design. So on the ceramic side, I think we would all agree that it's Biolox Delta, which is what we're talking about, and every company is using that. But on the poly side, there are different companies, and there are different manufacturing techniques and different, results. They've all performed relatively well, but there could be an issue there. In the history of ceramic on ceramic bearings, many of the long-term studies had problems with fixation. They weren't necessarily problems of the bearing. So that makes it a little difficult to interpret. But I think sometimes we get too general in talking about things when we need to get very, very specific. And then my last point would be the reality of the situation in the US is there is no ceramic on ceramic device available. So that makes it a lot easier for us to decide.
Yeah, I'd like to, on the same point that Amar raised, very important point that we all put the crosslink poly into one basket. There may be, recently there was a report about the Exactech, right, from HHS. So you don't know. So the question is, each company says obviously their poly, crosslink poly is the best. Now, when will we know this, which is the best? 15 years, 20 years? And that really is the problem. Whereas in ceramic on ceramic, we all agree it's going to be from Ceramtech, no matter which company that you use. We said the head is also going to be from Ceramtech. The line is also going to be from Ceramtech. So you are sort of insured in that way. We're not sort of having a lottery, as you know, we'll wait for 15 years to see whether that company's crossing poly will work or will not work. So here is an insurance against, especially in very young patients.
But again, Vijay, I think the fixation of ceramic liner inside the cup differs amongst companies as well. So if you take, say, Smith & Nephew, you got a metal ring around it, which can cause issues. The tapers for the ceramic on the outside are different with different companies. So there is again,
sure, yeah, I take your point, but these come out very early, yeah. So for example, the Smith & Nephew with the metal liner has been withdrawn. These are early problems, whereas the crosslink poly, as Amar said, most are good. So you will get to know later on. You will get to know only at 15 years, and that's the problem that we have.
I'm not fully agree with you, Vijay, because here, at least here in Germany, we have 4 different manufacturers for ceramic, 3 beside of Ceramtech. So there are probably some differences, and there are coming up new companies on the market who are producing ceramic as well. So Rajiv, you are a hip specialist, and Rajesh, and Rajiv, what are you doing in case of a complication? Let's say if you have a liner fracture or a ceramic head fracture, I mean ceramic liner, what is your procedure? What is your philosophy to solve this problem of ceramic fracture?
Well, to be frank, I have not seen a single ceramic head or a liner crack at present. I have seen one case who had a liner crack, but it was very difficult to tell him that you get it done. It was done somewhere else in Mumbai, and he came to us and he said that he feels a little funny in his hip, and took the X-ray. You could see the particulate matter all around the hip, but However, we tried to convince him. He was quite asymptomatic in the sense that he would get a click once in a while, but he was comfortable walking around and he didn't come back to us. But if I had to revise it, then probably you use a option head, and I would go again with this. That time I would probably go in with a ceramic and ceramic again, and make sure that the liner is sitting much better than what it was sitting previously. I very much believe that the reason for squeaking and the reason for fracture, both are going to be a bad alignment between the basic shell and the liner which you're going to put in. And the squeaking is, I feel it is more like a point load when the cup is very open book type of a thing, and then, or in a case in which you have done it through a very, very small incision and the whole thing is tight in itself. Those are the cases, like if you have an old excision arthroplasty or something and you try to put in a ceramic on ceramic and that thing squeaks on table. I mean, if you put a liner on and just put the trial liners on, even they squeak. I've seen it in one case and I had to go back from putting a ceramic on ceramic to ceramic on poly, but that was only one case in which I did, because we had to bring down the thing and the whole thing was such a tight fit that it squeaked. Till now, we've done something to the tune of about 300 plus cases of ceramic on ceramic. We are nearing around 7 to 8 years of time duration in 50% of those cases. And I've had one case who squeaked for some time and it disappeared on its own. I don't know why it squeaked, but that was happening when he was bending down and then bending his knees and trying to get up from that position. Sometimes it would squeak for him, but he couldn't demonstrate it to me. So I never really saw any case of squeaking also.
Amar, how many patients with squeaking have you seen in your career, and how many ceramic fractures have you seen? And how did you solve it?
So I've seen no ceramic head fractures with Biolox Delta. I have seen many Forte head fractures and many Forte alumina liner fractures. The squeaking, I think a lot of the squeaking also, to my earlier point, was design related. There was a Stryker version that had a much higher incidence of squeaking than other designs. And it may have to do, Dr. Walter in Australia thought that the resonance of the metal, the TMZF metal, may have influenced the amplification of the sound. But it's no question, regardless of design, squeaking does occur with a ceramic on ceramic hip. And it's a low rate. It's certainly not a very high rate, but it's a very uncomfortable thing for the patient. The other thing, you were describing all these patients who were putting their hips in extreme ranges of motion. I think poly is much more tolerant of extreme ranges of motion and impingement than a ceramic on ceramic bearing. So I would be careful of allowing your patients with those ceramic on ceramic bearings to achieve those levels of range of motion.
What's your solution in case of ceramic fracture? What bearing do you use in revision?
So we published on that because we did use Forte for a while and we saw some fractures. I think the key is to do a thorough synovectomy. So I will go, I usually do a posterior approach, but from the same incision, I will do an anterior dissection and basically an anterolateral exposure, and then make sure you remove all the broken parts. So the synovectomy is the most important thing. Ideally then, putting in another ceramic and ceramic bearing would be the best thing to do. Most of those patients, however, are hesitant to do that. So what I do nowadays is I put in a ceramic head delta with a titanium sleeve, and I'll use highly crossing poly, but make sure I do a thorough synovectomy.
Sahil, are you doing the same? Ceramic on polyethylene in revision of ceramic fracture?
Yes, pretty much the same.
Vijay?
Yeah, I agree with Amar. In about 2010-11, there was a school of thought that you must use only ceramic on ceramic I've handled a lot of them. I get a lot of referrals for them. That you must use only ceramic on ceramic in the revisions. And as I think Rajiv said, certainly I will not retain the cup if I'm doing ceramic. I mean, I'm talking about a decade ago. We used to revise the cup and then do a ceramic on ceramic. But now after Ranawat published this paper, we're confident of using poly. And sometimes, with a hooded poly, etc., you may be able to get away with the same cup. And we do a synovectomy, as Amar said. And touch wood, we haven't had any issues. We, of course, never use a metal head. It's always ceramic head. We've not had any problem in using a ceramic on poly bearing for a ceramic fracture so far.
Okay. Sahil, we are talking all the time about ceramic on polyethylene, but there are existing still some old polyethylene cups. How often do you use, or do you differentiate, have a differential therapy between highly cross-linked and the old polyethylene, which is not highly cross-linked? Do you use it sometimes? I mean, for example, due to the costs?
No, we're only using highly cross-linked polyethylene, not using the old one at all.
Okay, Rajiv, same in Pune? Rajiv?
I have not used the old poly for a long time, in 20 years.
So everybody is using the highly cross-linked polyethylene at the moment, and I think that's a good choice. So to summarize it a little bit, there are many different cutoffs between in the age groups. Ceramic by using ceramic on ceramic. Vijay said his cutoff is 30 years. Rajiv said his cutoff is 55 years. So, and Sahil, do you also have a cutoff?
About 35 to 40.
35 to 40. So there's a wide range okay. Are there any questions from the panelists? Yeah, Sahil.
2 questions. First thing is, one of the most common questions were asked by the patients in the OPD, and that is, when we tell them about the bearing surface, they often ask, how many years is my hip going to last? So I want to know the answer of all the panelists, that what do you say for COP or for COC? And the second part of the question is, does your cup positioning alter with your choice of bearing surface? Would you want a more closed book cup with ceramic on ceramic to avoid edge loading or impingement and those issues? Or what's your target cup inclination and version?
Mahesh, would you like to answer these questions?
So there is a good paper from Lancet about the longevity of a hip replacement, which has been published, which I routinely use in practice to tell the patients about how long are they going to last. So I think it says about 85% last for at least 25 years, if I'm not mistaken. And the second question was about the inclination of the cup. With highly cross-linked polythene and ceramic, probably you wouldn't make much of a difference between changing the orientation of cup. I would treat both of them pretty much in the same fashion, because the highly cross-linked poly is as brittle as ceramic.
So your target inclination is?
So the target inclination. Yeah, I would close the cup more than the standard teaching of 45 to 50 degrees of inclination. So the cup will be more closed in the case of both of these bearings.
Amar, what are you saying about longevity and positioning?
Yes, I would agree. I say 25 to 30 years. And for the vast majority of patients, that is certainly more than enough. As I don't do ceramic on ceramic, I don't alter my positioning for the cup. But I want to make a point that I think often gets overlooked. We talk about an age cutoff for using a different bearing. But the most important thing when we do an arthroplasty is not the bearing. It's not the alignment of the components. It's fixation. And if you use a different system because you want to get that ceramic on ceramic bearing in a young person, and a system you're not as familiar with, the reaming can be a little different, the broaching can be a little different. If you fail on fixation in that young person, you have totally failed that person. So I think that's the key, is make sure you get good fixation, and whichever bearing you use, you're going to give that person probably 20 years of pain relief. And by any measure, that's a good deal. but don't fail on fixation.
Rajesh?
I have a question for Vijay. As Vijay mentioned that in Indian patients, the socket size is very small, and he prefers to use a monoblock cup, which allows us to use a bigger head. Vijay, do you think a dual mobility now is a good option as well for these younger patients, or we still a little bit suspicious of the long-term outcome of dual mobility vis-a-vis a ceramic on ceramic with a monoblock cup?
Yeah, we don't know about dual mobility in young patients, although a lot of French literature says it's okay. I'm very skeptical about it. Yeah. So you can't have everything in life. There's a give and take always. And so I'm very skeptical in using dual mobility, especially the one with the liner that you put in young patients. I'm very happy to use them in elderly patients, dislocation, etc. But I would be very skeptical in using that. Yeah. I have used Forte on Forte, my own experience now 18 years. I have patients. Now the difference between conventional poly and ceramic on ceramic is that in conventional poly, on 20th year, it didn't fail like that. You could see the failure on the X-rays going down like that. Yeah. But here you have a 20-year X-ray, which is pristine. It's not a fail. It's pristine as day one. And that's why I'm much more optimistic about longevity of hips, whether even cross-linked poly or ceramic or much more than 20-25. That's very conservative in my opinion, because we are not seeing that a ladder that's coming down a slippery slope. It's like day one X-ray. So I'm much more. And then fixation has been solved to a large extent, I think. Fixation, unlike cement, which is just a time clock waiting to fail, a non-cemented process just doesn't fail in that mode. So somebody has to invent a new failure mode for these to fail. We're just interpreting conventional poly, superimposing our concept on this. So I'm much more optimistic than your values. But I'd like to make one philosophical point. Now we have ceramic on ceramic, we have ceramic on cross-linked poly. Now you can cross-link more and more and get wear resistance, but you are going towards the ceramic side. The more cross-linked poly is going to behave just like a ceramic. It gives the ceramic properties. Yeah. So it's a give and take. Do you want to wear, or do you want a bit of fracture problems? And so it's like that. So cross-linked poly. If you don't cross-link so much, you will get much better longevity than conventional poly. Is very safe for your extreme actions, etc. Safe, but then you have to pay a price for the longevity. So it's a give and take there.
And your target cup inclination?
Well, I'll go native in all the patients, like the X-rays that I showed. It's in the region of around 40 to 43 degrees. But I would go native for that patient based on the transverse acetabular ligament, and I'll ignore whatever is the superior landmark.
Thank you so much. Rajiv, any comment about it? What are you saying about longevity of your implants?
Longevity is something it is very difficult to really comment, and that depends a lot on how good the patient is going to really do his exercise in the end, or how active it's really going to be. The problem is, once that pain goes away, I've seen a majority of the patients land up putting on a lot of weight, and not only putting on a lot of weight, they decrease their outdoor activities per se. Somehow, it doesn't make sense, because now it's not painful, they should be going out. But a lot of them don't do. They are so stuck up in the job or something, they're putting on weight, the muscle strength is going down. And these people, somewhere or the other, the bone stock starts dwindling. And if that happens, and then subsequently, if there's going to be any injury or something, a micro crack somewhere, and then you can start getting a problem. So I'm not sure of that. I tell them your joint in the bearing per se can last you a lifetime, whatever you're going to use. But that's not enough. You have to do some exercise, make sure you're fit, make sure your weight is under control. And Dr. Vijay allows them sitting on the ground and everything. I'm very scared of allowing them, because it's like if you allow them that, then the next thing you know that I have a patient of mine. He is a young person who's in police service. So his wife rang me up once and says that this fellow went chasing after some person who was running away, and then he kicked open the door. He's got a unilateral ceramic on ceramic. He kicked open the door, went inside, caught him. So please tell him not to do such things. These are, you're putting that, in the end, it is an artificial joint. It is not something which is nature which has given you. It has no healing potential. Even if it cracks somewhere or something loosens out somewhere, it is going to become more and more with time. And with majority of the patients, they don't understand that when you're looking at an artificial thing, you're looking at something with a little bit of restriction. I would tell all my patients that, when you're taking a hip joint replacement, that's your girlfriend, it's not a wife. I mean, an Indian wife, even if she is mad at you, she'll still feed you, but this is a girlfriend. You don't listen to your joint is going to screw your happiness really left, right, and center, and majority of them do understand that.
Very pessimistic. Can I just comment on that? Very pessimistic view, Rajiv. When they, earlier people used to say it's artificial, so it can't last forever. Forever doesn't mean millions of years. Forever means only the longevity of a person. Now, assume we find a material which lasts for 100 years. That is forever. Now,
yeah, for his life,
that philosophical statement, nothing lasts forever and all, it's okay, but you must interpret it within that. So it won't last for millions of years. But we are not going to live for millions of years. So that way, it may be an everlasting solution. Similarly, have you seen any problem with your patient doing any activity? I have not seen in 20 years. So what are you saying? You should not restrict them. I know now why your patients are not active. We already told them not to be active. That's why they're not active. My patients are very active.
Okay. So last but not least, I've forgotten to ask you, Mahesh, what is your differential therapy, or do you have a differential therapy in treating the patients? Do you all treat all the patients with COC or COP? Or
Yeah.
are you using like still metal on metal bearing surface replacements?
Now, personally, I am not using any metal on metal or surface replacements. I use oxidized ceramicized metal in a few of the cases, along with the implant of choice if it belongs to that company. Majority of my cases are ceramic on poly, unless the patient is aware of the bearing options that is present and he demands for a ceramic on ceramic bearing specifically.
I'll just make one point, Thurston, on this ceramicized metal. The reason I use a lot of them is that in our Asian patients, our offset is so low that the ceramics just not manufacture those minus heads,
Minus heads, yeah.
So in those patients, if you put this head, they are so uncomfortable. You increase their offset, they have trochanteric pain, etc. In that case, the ceramicized metal really is helpful in that situation in Asian patients.
So thank you all so much, because our time is
one last question, Thorsten.
2 minutes, and I'd like to hand back to our host, Parag.
Yeah, so I'll just ask the last question before we end to Amar, Vijay, and Thorsten as well. What do you see in 10 years' time, Vijay, Amar, and Thorsten, the bearing surfaces will be the same what we discussed? In the younger, you go for ceramic on ceramic, elderly, you do ceramic on poly. What change do you see 10 years from now? Vijay?
Well, we first need a problem to solve. So as I said earlier, we're trying to impose our concept on conventional poly on these. So we seem to have solved fixation with non-cemented both sides. We seem to not wear to a large extent. We currently don't have, and if you are able to use bigger heads in smaller patients, you solve dislocation also, provided you know how to put your components. So I don't see any point in trying to solve a problem that you don't have.
No, but
it'll be the same.
Yeah. Changing the bearing surfaces 10 years hence. So
why do you want to change it? Yeah, there's no problem to solve here.
To go for longevity from 30 years to 40 years.
We are already very close to it, I think. Yeah, we're already very close to it. Yeah. Okay. And then, as I told you, conservative revisions. We have. I mean, to test a new bearing will take 20 years. So that's the reason why I'm. Amar, if something lasts for 5 years, I'd go for it. Yeah, I mean, in the sense to test it. Yeah.
Got it, Amar.
Yeah, I mean, I think technology always marches on. And there's always a push from industry to try to create the new thing. However, the problem is, as Vijay is describing, the hip is a nearly perfect operation. Nearly perfect. The odds of you making the operation better with a change is exceptionally low. The odds of you making it worse with a change, and that's one of the reasons why I don't like dual mobility, is much higher. So I think change in the hip replacement field should be taken very, very cautiously. And I expect in the next 10 years, there to be not much difference in what we're doing today.
Okay. Thorsten, your concluding remarks.
Yeah, almost the same here. To be honest, we are talking about a procedure which is now 60 years old, and regarding material and bearing, something of course has changed here in the last 60 years. but nothing dramatic. It was, so I do not believe that in 10 years we will implant some other materials or other bearings. 10-year period is for me too short, and as Amar said, we are talking about an almost perfect operation, and I do not believe that the bearings makes a difference. Our next goal should be to reduce complications, of course, but this has nothing to do with the bearing, in my opinion.
Before I hand, Amar.
Yeah, I mean, I think the changes that are going to come are not going to be in implant design. They're going to be, you know, as we mentioned before, I think Vijay mentioned tranexamic acid, right? That became a game changer. So peri-operative anesthesia, pain management, maybe wound closure, you know, infection mitigation. Those are the things that are going to have the potential for improvement and change, not the implant design.
I agree with that. That's the reason probably the anterior hip has also gained a lot of traction, because there's nothing else to do with the implant. So something has to change. So people went anterior.
I agree with that statement too.
Yeah, so exactly. So before Sahil concludes, I'd just like to end on a philosophical note. I think whatever in orthopedics, we've seen that the procedure, what we do now in 10 years time, it does undergo a change. And we've seen that historically. So I don't know, in 2030, we all will be there. We'll all discuss. I don't know whether Vijay Amar would have to eat his words, eat their words. I don't know. Let's see. Let's discuss that in 2030.
Look forward to that.
Sahil.
I'll bet my hair.
That'll come.
So, thank you once again.
I think we should close this session, a wonderful session. I'd like to thank all of you so much, because we had a great discussion and great talks from Amar and Vijay. I think it was a perfect overview about the current status of bearings, and I'd like to thank especially my friend Parag and his father, of course, to organize this meeting, and thank you so much. Hope to see you soon.
Thanks, everyone. Thanks again. Great to participate.
Great seeing you all.
Thanks.
Bye, Amar. Bye, Thurston.
Bye, everyone.
Good day to you all.